Welcome to the Faculty of Agricultural and Food Sciences seminar, and I'd like to introduce Dr. Eric Gruen, who's the head of Agricultural Economics and Agribusiness, to introduce today's speaker.
Hi everyone. Welcome to the last Agricultural and Food Science Faculty Seminar of 2017. I'd like to let everyone know that our department still has one more seminar coming on December 14th, just at the end of the Manitoba Agricultural Agrologists Conference. Mike Gifford was a negotiator with NAFTA, and he'll be speaking over in the Tier seminar room at noon on December 14th, and our 22nd Fields on Wheels will be happening the next day, December 15th. The details are in Crystal's newsletter, so I just sort of got to put that plug in for our department. And then Fields on Wheels is jointly supported by our department and the Transportation Institute. So it is my pleasure to introduce Dr. Jared Carlberg, who, despite his work as Associate Dean Academic, has kept a fairly busy research program going. Lately it's been in the area of measuring healthcare savings from food-related diseases. Dr. Carlberg has an PhD in agricultural economics from Oklahoma State University. He's got a joint Bachelor of Commerce, Bachelor of Honors in Economics, and a Master's in Agricultural Economics, all from the University of Saskatchewan. He was raised on a mixed farm in southeast Saskatchewan. Dr. Carlberg has over 45 peer-reviewed articles and technical reports. He's an award-winning teacher of econometrics, price analysis, and marketing. He's broadly interested in the whole supply chain. He's worked on farm-level management choices, processing in beef retail, and lately he's turned his interest to nutraceuticals. Please join me in welcoming Dr. Jared Carlberg.
Thank you very much, Derek and Dr. Scanlon. I didn't write any of that, so I'm appreciative of the recognition and praise from my department head. Thank you very much. So this doesn't represent the title that you probably saw on the research posters that were put around. I received clear direction from the Associate Dean Research to come up with a more provocative title, which I did. And so the answer is yes, in Canada, maybe even in Manitoba, but certainly in Canada. And so over the next while, I'll proceed through just an exploration and an explanation of the research that I've been doing, mostly in conjunction and partnership with Peter Jones and our research team out of the Richardson Center for Functional Foods and Nutraceuticals here on campus. So when I was first approached by the department head, he said, you know what, it's your turn to do a seminar again. I did one in this room back in about 2005. And it was on farmland values in the Red River Valley, a topic that I'm still working on. I actually have a couple of different graduate students that are actively doing their MSc thesis research on that topic. So still involved with this, and hopefully will still be involved with the current line of research that I'm talking about 10 years from now. But when I first was approached by Derek and he said it was your turn to do the seminar, I thought, what am I good at? What do I actually know something about that I would stand up in front of my colleagues in the world to speak about? And the best that I could come up with was that. So my confidential assistant, Heather Weeb, put this poster together. It was kiboshed by my friend and colleague, Dr. Scanlon, so we worked on a different topic. So as Derek noted, I have been doing a lot of research the last several years, about 10 years or so actually. I still am an active researcher in the area of agricultural marketing, but have become really interested in the economics of healthcare costs, mostly as a taxpayer. So what I tell graduate students when they're starting out or about to do their own research seminar, etc., you have to answer the who cares question. So I'll spend some time at the outset of, or the early part of the presentation, talking about healthcare costs and why we should care about them. We'll look over the methodology. So we've now done this, half a dozen times, more or less, and published our results in some pretty decent journals, mostly in the food science and nutrition area, but also in pharmacology, And so I think it's pretty interesting research. It's certainly been something I've enjoyed working on collaboratively with colleagues in food science and human nutritional sciences. So even though on the first slide we said I'm in Agribusiness and Agricultural Economics, which is true, I'm cross-appointed into the Department of Food and Human Nutritional Sciences, although Jim House doesn't allow me to put that on the title slide when I speak. It's probably the beer thing. That's what I'll tell myself. In general, we think reducing healthcare costs would be a big thing. Healthcare costs now account for more than 50 cents out of every tax dollar. So that's really, really a lot. So this slide probably, or this graphic probably came from the US, where this would be someone paying for their own. But since we all pay for each other's, I think this guy is probably a taxpayer right here. And so, of course, just a little bit of a nod to the fact that healthcare costs are really, really high. So just some random sort of facts to throw at you. This is a little bit dated, but only from a few years ago. 1 in 12 people with diabetes, half of those don't know they have it. So that's a lot. 1 in 9 healthcare dollars globally spent on curing diabetes, one of the most important, what I'll call food-related chronic diseases. I've done a little bit of undergraduate teaching on this stuff as well, but not for a few years now. It's something I'd like to get back to. Cardiovascular disease, though, is the really big one. And so leading cause of morbidity and mortality, so morbidity just general sickness, obviously mortality being death, causes more than 3 out of every 10 deaths, and an estimated 17.3 million deaths each year worldwide. So a big deal. So from a Canadian source, hard to see down there, system of health accounts, but from OECD, we see Canada right there about the middle at spending 10.4% of our GDP on healthcare. I think one of our favorite things to do as Canadians is to feel smugly superior to the United States. And so we can do that in yet another way, not just hockey and curling, but also in terms of what we are able to do through our publicly funded healthcare system in terms of overall expenditures at roughly half of what the US has and 10.4% of GDP as opposed to their nearly 17%. Provincially, we look like this. So just a little bit. We see in the northern territories and provinces that we have some pretty high per capita healthcare costs. And see, I was told this laser pointer would work. It's not mine. I have at least one student from my econometrics course that I teach in this room thrice weekly here today. Riley's here. And he knows that my normal method of identifying things on a slide is a 75-year-old yardstick that I would, sort of beat on the screen with, but I can try and use this. Wow, it works, amazing. And so Manitoba here at 7182, and some really big numbers. That's less than half of what we see, for example, in Nunavut. So just you see numbers that are about the same across the province and right in line with that Canadian average from the previous slide. In total, though, a big number, $242 billion per year, a really big number, and you can see why we as taxpayers, setting aside the fact that what we do in terms of our nutritional choices in life leads to either, I'll get to it in a couple of slides, but a reasonably nice life with regular worries and stresses and health issues versus a very difficult one. So for me, about 9 years ago, my father passed away, had a stroke, lifelong smoker. And so at that time, that was, my aha moment where it's time to to start thinking about, at that time being sort of 35 years old, it's time to start thinking about those choices and where they might lead. So this is a really big number. This is a really big number, 242 billion. Consistently, about 70% of healthcare expenditures have been publicly funded and around just under a third privately funded. And that's stayed the same over time, as we see for the last almost 20 years. Again, not to belabor the point too much, just to underscore healthcare expenditures are important. They've been growing as a percentage share of gross domestic product, or GDP, which is, for non-economists, sort of just the overall value of the economy. And so we see a few spikes, but in general, an upward trend forecasted to be what we saw on the previous slide there as a value for 2017. What are the specific expenses that we spend money on? Hospitals are the largest part, right? Drugs are a large part. We see that physicians are a considerable part, as you might expect. As we get down a little bit further into the weeds with some of the results I'm going to show you later in the seminar, we'll see some of the other direct and indirect cost categories where healthcare expenditures are going. So we see this. This is all just sort of a little bit of a preliminary I guess, explanation of how we would answer the who cares questions. Who cares? Well, we all should for our own personal health and the comfort and kind of life we're going to lead as we age, but also as taxpayers and the people ultimately responsible for these expenditures. In Canada, it's a bit bigger deal. So the how are you going to feel as you age part and what are your later life years going to be like, that's relevant regardless of where you live and what the structure of who's responsible for healthcare expenditures might be. But in Canada, of course, we're doubly concerned because we're all responsible for these expenditures as taxpayers. Looking to more food-related chronic diseases, I've spoken a little bit about diabetes and cardiovascular disease or coronary heart disease as the big ones. Here's just some additional numbers. So expected to be 17 billion by 2020, okay, the economic burden associated with diabetes. Cardiovascular disease, all food-related chronic diseases, cardiovascular disease accounting for a huge amount of overall number of deaths in Canada, so it's important. It's all just underscoring the fact that this is important stuff. And so that's my answer to the who cares question. It is about your personal health and comfort, but it's also about the financial implications, where, of course, we as economists have the ability to make the greatest contributions. So I kind of like this kind of path, and this is what I've spoken about a little bit. So what do we hope to do? We hope to sort of go along the green road here, and we said there are probably some pretty nasty things, in both in terms of cost and in terms of our utility or satisfaction levels that we feel as we age, associated with the red row up there. And my wife keeps telling me I'm probably somewhere. There's no yellow line here, but if there were, that's where I might be. So I'm trying to do better. Of course, as an associate dean, I'm grotesquely overworked and underpaid, and so fewer afternoon trips to the gym to help get down to the green road. But I can't complain. Actually, I tremendously enjoy my academic and administrative responsibilities in the faculty. In terms of what's ideal, how do we think it should work? So we've got some colleagues here from the Manitoba government today, and I'm delighted they could make it down. This is how the system probably ought to work. So most of us in the room here, not everybody, most of us are either here or aspire to be. So we've got health-based evidence, economic evidence. Nutrition economics is really the intersection of those disciplines. Our colleagues and friends from the government are here. And they also have big stakes here, and the government folks have stakes down here as well. We would like to have a healthy, thriving food industry and food processing industry in the province, not only in terms of primary production, but certainly in terms of food processing. We've had some really big wins lately for the province, and one of our goals is to keep those wins coming. So one of the things I think a lot about is, okay, so we know there are things that you can eat or specific nutrients you can consume that are going to make you healthier. They're going to accomplish both of the goals we've been talking about, which is a happier, healthier life and reduced healthcare expenditures. What can Manitoba do? What can we do? We've got this faculty and province full of brilliant and accomplished scientists. A lot of them are here today. We've got a government that really cares about things and is confounded by budgetary issues that we as taxpayers are ultimately responsible for. They're interested in addressing that. Anything that can kind of maybe not reduce expenditures but stop them from growing more quickly is important to them as well. The industry, we can create jobs and we can create demand through some of these processed products. For our primary agricultural commodities, we can help farmers win. There's wins here for jobs, for farmers, for government, for industry, for everybody. And so I think it's a really exciting line of research from that perspective. So I like the system, and I might return to it time permitting later on. Nutrition economics is sort of where I think Peter Jones and I, my frequent collaborator, the director of the Richardson Center for Functional Foods and Nutraceuticals, and our research team nutrition economics is sort of where we think the intersection of our two disciplines is. So I'm going to present some fairly technical stuff later on that is quite in the area of food science and nutrition, and some stuff that's in the area of economics. So being a part of these interdisciplinary research teams has been really rewarding and enjoyable. It's helped me learn about some things I didn't know a whole lot about before. So we've got nutrition, we've got economics. There's traditionally been health economics field. There are some really good journals in that area, and there's lots of types of economic analyses that pertain to health economics. What we've sort of been at the forefront of helping develop, though, is the idea of nutrition economics, maybe as a subfield of health economics, maybe even as its own. I kind of came up with my own definition for a presentation that I did on this topic on an international symposium on diabetes and nutrition in Toronto a couple of years ago in 2015. I would argue nutrition economics explores the relationships between food, nutrition, disease, healthcare states, and the financial dimensions thereof. It really is about those questions of what are the healthcare cost implications of eating healthier, of reducing disease costs. And I think there is a whole other dimension that we're still learning to explore that goes more to the economic benefit side. It's not just about how many dollars can we save, it's about how many dollars can we generate. Not only could those saved dollars be reallocated to higher value uses, but also the economic implications of an expanded processing industry, more jobs, increased demand, and maybe even better prices for our commodities could result. So I think it's a really exciting area from all those perspectives. I'm not going to get too far down into definitions. Pleased to send the slide deck along to anyone that wants it and or any of the publications that I'm going to talk about today that have resulted from this research. There are different ways, though. So if we talk about nutrition economics as just defined as a field within or next to health economics, there's different things you can do to try to decide really what we're talking about. Economics, I've always thought, reflected on as being a discipline that can have a really complicated definition, you know, allocation of scarce resources among competing interests. I tend to like things simple. So I think economics is the science of choice. So really what we're talking about is from a public health care expenditure or public economic standpoint, what are the choices we're going to make in how we allocate resources? And there's different ways to look at these. So in the health economics literature, you have cost-benefit analysis, cost-effectiveness analysis. The one that we've sort of focused on so far of cost of illness analysis, there are some others. Cost of illness, you see a definition here, is how it's kind of distinct from cost-benefit analysis and cost-effectiveness analysis. But really what we're looking at is, in this case, looking at the direct and indirect costs of diseases as defined in healthcare expenditures. What have we done is develop a socioeconomic model to evaluate healthcare cost savings that could arise if eating patterns or other food consumption patterns changed. What we usually have to do is what we've referred to as a scoping review, almost a literature review. So there's a couple of component parts. We'll talk about it as we get a little bit into more detail with specific studies that we've undertaken. But really what we're talking about is having to undertake a four-step analysis. The important steps pertain to relying on meta-analyses from the natural sciences, nutrition and food science, to decide how blood chemistry, for example, is going to change as a result of a change in what you eat or consumption of what we might call a bioactive. So you eat something that's good for you or eat less of something that's bad for you, that's going to change your blood chemistry. It's going to lead to an improved health state. That's going to lead to fewer visits to the doctor and or hospital and or fewer drugs, and that's going to lower those healthcare costs. So in a nutshell, it is really collaborative interdisciplinary research where my colleagues in food and human nutritional sciences are the ones that know the literature and know the science really well about blood chemistry and specific nutrients or bioactives. We as economists have the role of doing the other things that I think are much more interesting in terms of calculating cost savings, et cetera, and making those choices or advising regulators on those choices. So we basically have what we call this four-step approach. We have to decide. So we might know, the last research that I'll speak about today will be the most recently published in a really good journal in the food science discipline called Nutrients. And what we really have to do is, if we know that stopping eating something, like reducing your sodium consumption maybe might be something we look at, or increasing your consumption of plant sterols, and I'll speak to that specific work that we did soon. We have to know how many people is it reasonable to assume are going to do the thing that's good for them, or stop doing the thing that's bad for them. So we need an estimate of what we call a success rate. This is the crux of the kind of analyses we do. We have to estimate that. We base it usually, there's a couple of ways you could figure this out, and I've seen work done both ways. You could base it upon, say, a survey or some other kind of experiment where you'd say, okay, if this happens, what are you likely to do? And you might get people, you might email them a survey or mail them a survey, something like that. You might hire a survey monkey or a Qualtrics or somebody to help you with this, to get a sample of data. I've had research, not in this line of research, but I've had graduate students that conducted experimental auctions in grocery stores in and around Winnipeg. That research has been cited around 50 times. A graduate student from about 10 years ago. So there are different ways to assess what people are actually going to do. As we economists know, there are stated and revealed preferences. People don't always do what they say they're going to do. Unfortunately, most of us have learned that the hard way in other parts of life. But either way, step one, what are people likely to do? You have to assess that, and it's usually based upon a review of the literature, and you have big ranges. As we'll learn, we actually take at least 4 scenarios into account when we do these. An optimistic scenario, a very pessimistic scenario, and then some scenarios in between. So as a result of that, what happens? If you eat more plant sterols, what happens to your cholesterol? As a result, what happens in terms of your likelihood of getting cardiovascular disease? And if we have people, if we do believe that as a result of eating more plant sterols, there's going to be a reduction in cholesterol, and thus a reduction in coronary heart disease, how do we calculate the cost savings associated with that? So it's the 4-step approach we've kind of used, kind of based upon what we've seen in the health economics literature, but we're also making improvements to the model that I'll talk about at the end of the lecture today. So again, kind of pessimistic versus what we would call universal scenarios. Everybody does it, almost nobody does it, reality somewhere in between. I'm going to try and go a little bit quicker because this stuff's really exciting, and sometimes I want to talk about it for longer than I should. The first work we ever did in this area was carried out, so I was the PI on the grant from the Coalition for the Advancement of Plant Sterols in Canada, or CAPSIC. At the time, we started to get interested in this research, again, working with my colleague Peter Jones from the Richardson Center. At that time, plant sterols weren't, so plant sterols basically prevent the body from absorbing cholesterol. So you can eat the same stuff, absorb less cholesterol. It means that your blood cholesterol level is lower, it means you're healthier, and if everybody did it, that would result in fewer cases of cardiovascular disease and fewer healthcare expenditures associated therewith. And so this was our sort of inaugural work in this area, published in a pretty good journal, Food and Nutrition Research, and a fairly long list of authors, but my graduate student, Colin Giles, is the first author. I was the senior author and PI on the grant, and of course, Peter Jones is a co-author, and some staff from the Richardson Center that contributed to that work as well. That are named. So again, what did we do? Trying to figure out what healthcare savings could look like, and this was our first foray into this 4-step analysis. At that time, plant sterols were not licensed for use in Canada. Literally every other major industrialized country in the world had licensed them, and so we basically were trying to demonstrate that doing this would potentially lead to some reductions in healthcare expenditures. We were successful, or the efforts of the lobbying agency CAPSIC were successful, and we contributed to that. And so plant sterols have been on the market in Canada for a long time. I was actually kind of irritated a few years ago because I had a daily yogurt drink with plant sterols added that I had gotten really used to, and I was quite proud of my low cholesterol. For some reason, I think it was Danone that took that product off the market, and now I drink plant sterol enhanced orange juice instead. So plug for Minute Maid there. So we did the same thing. We went through our 4 steps. And what we found was, so again, how many people are likely to do this? Well, there's a range of estimates. So we said, okay, well, if everyone who is predisposed to purchasing functional food, based upon survey data from Harath et al., we could have as many as 47% of the people in Canada consuming plant sterols. It could be as little as 0 down here at the bottom, or it could be somewhere in between. In the end, as we'll see in the summary slide on this work, I think we picked 17, and that was a country we found, Finland, that was fairly similar to Canada in important ways, and we said this might be a reasonable assumption. But of course, we considered all the potential scenarios. So what would happen? We've got a range of potential cholesterol reduction rates. We have got a range of potential reduction in the incidence of coronary heart disease, CHD. And so this is all based on meta-analyses from the food and nutrition literature. So these aren't things that we're just making up. These are things that came from the literature that our science colleagues, natural science colleagues, came up with. So just a little bit, so we spoke, I had a slide up at the outset of the presentation that really focused on, as I recall, hospital and drugs and physician care. We see these as those as some of the big categories, but then direct costs. So the $242 billion that we talked about earlier is direct costs. There's a lot of people who are really interested in the indirect costs. People die. People are on long-term or short-term disability. There are other things. This isn't even an exhaustive accounting of all the types of healthcare costs that can result from morbidity and mortality. So there's a long list. So then we look at reduction in cost. Now we know that in Canada, 84% of healthcare costs are fixed and 16% are variable. So what we do is try to weight these things. We're not trying to overstate the results. We're not trying to say the research is something that it isn't. We're trying to come up with an honest accounting of what we think will happen given changes in eating behaviors. In the end, we get down to this, though. So table 4 from the paper, and we see the potential in terms of success rate. So ideal or universal scenario that we talked about at the outset, down to very pessimistic, being essentially nobody, 1 in 20 people deciding. So this, what are we saying here? Between half, if plant sterols were available, and this was before they were licensed for use in Canada, between half and 1 in 20 people somewhere are likely to actually consume these things. As a result of that, we have a lot of, at the different rates, we have some variability in cholesterol reduction. Could be up to 10, 11%, say, as low as 5. As a result, there could be this set somewhere in here of coronary heart disease reduction due to a 1% reduction in cholesterol. That leads us then to a set again of potential outcomes from plant sterol consumption given the sensitivity analyses that we've undertaken. So again, we said sort of worst case scenario, very pessimistic across the board, $37.8 million per year savings. That's across Canada. It sounds like a big number. It's a rounding error probably somewhere in Health Canada's accounts. But at the very best case scenario, is this going to happen? Probably not. $2.5 billion per year in saving as a result of plant sterol consumption. But that's the range. So what we've done subsequently, we've implemented this same methodology a number of times. What we're working on now that I'll get to at the end of the set of slides is how we improve the methodology, because that's our goal. So we think the science is right, we like the economics, and we want the economics to continue to improve in terms of its precision. That's what we're working on. Our second work in this area, really as the area of nutrition economics started to develop, we were some of the folks working on this early. So I received a grant from Danone Institute International back in around 2010 or so. So on this paper, I was the corresponding and senior author and principal investigator on the grant. And my student again, Colin Giles, who's my PhD student now and is doing his proposal defense on, so master's student at the time, PhD student now, doing his proposal defense on Friday. And our contact at Danone Institute International, of course, Dr. Jones again, assisting in the research, and then some folks that helped out with various parts of the research. So what we really saw at this point was the discipline of nutrition economics kind of developing. So our co-author, Irene Lenore-Wincoop from Danone in France, had done some early work on it. Peter had participated. And what we really did in this paper was go out there and say, okay, actually people have been doing kind of the same stuff that we're interested in different settings and different venues for some time, but not cohesively, not with the set of assumptions or methodology that we're interested in using. So we really did what we called a global literature review, and we broke it down into economic studies of micronutrient deficiencies and malnutrition, economic studies of dietary improvements, and economic studies of functional foods. So we had quite a lot of studies, close to 100 studies that we looked at and categorized. This was published in Nutrition Reviews 5 years ago. Nutrition Reviews is really highly ranked journal in the field of nutrition and dietetics. And so it was quite nice to get this study published there, and that study's been cited subsequently in the literature fairly extensively. So quite proud of that. The next thing that we kind of got involved with is Peter Jones and I were co-principal investigators on a grant from Kellogg Canada. And we decided to look at the effects of, so Kellogg wants to sell you more Special K and improve your consumption of dietary fiber. It's okay that they have a commercial interest in that. We economists are okay with understanding people's motivations and incentives and the financial aspects thereof. But we really had two things we were looking at. So if we increase dietary fiber, we reduce functional constipation and irregularity, which, yeah, does have healthcare costs associated with it, and then looked also at the effects of increased fiber consumption on type 2 diabetes and CVD. That was our next foray into this, using a similar methodology that we've continued to improve over time. So what did we do? So dietary fiber valuation with those two components. The first one was published in this journal, again called Food Nutrition Research, which was the same outlet for our plant sterols research, a well-regarded journal in the food science area. And it was entitled Dietary Fiber Intakes and Reduction of Functional Constipation Rates Among Canadian Adults, Cost of Illness Analysis. So lead author on that was Mohammed, who's worked with us a number of times and maintains a research interest. We're still doing collaborative research with Peter and I, again, as the co-principal investigators on this. So without wanting to get too much into the nitty-gritty, constipation almost seems, we're not used to talking about this, but it's an issue. So more than a quarter of people experiencing, and it results in, so this is not per capita, but per constipated patient basis. The costs are not insignificant. Healthcare is really expensive. In Canada, we all pay for it. So we all have an interest in helping reduce these things if we can. So dietary fiber is a really well-known way to combat this. So here's the part of the, remember we had the 70-30 public-private split? So lots of private costs associated as well. That's money people aren't spending on other things that might spur other parts of the economy. So to get down to a little bit of what the analysis itself looks like, so basically looking at trying to get men to about double their current fiber intake in terms of grams of fiber per day, and women to do a little bit, not increase by quite a factor of 2, but close. So what are we talking about? Again, we see current based on assessments of what people are eating now, and we see how percentage reductions per gram of fiber intake, again from previous research. And we said if we hit those targets of 38 grams per day and 25 grams per day, we could save up to $45.6 million in healthcare costs. That's the best case scenario, so I can provide the tables to anyone who's interested, or the paper itself. I'm happy to send that to you. And so even if it's only $2 million, that's still something. It pays for the education program maybe to help spread the word about all this. So we'll get a little bit more into that at the end of the presentation. So it's important without spending too much on that. So again, just from our scenarios, and we don't have the most pessimistic scenario on there, obviously the smallest. It somehow didn't make it onto up here on the slide. But we see what we could have in terms of healthcare savings given on those specific cost categories, given the different scenarios. So that was the constipation valuation that we did. Recall that when we received this grant from Kellogg, we agreed to look at also the impacts of dietary fiber, not only on constipation, but also on type 2 diabetes and cardiovascular disease. So we published those results in Frontiers in Pharmacology, which is quite a good journal in the medical pharmacology field. And so that was published in 2015. Same kind of idea. Same kind of idea. So what do we have? Again, we see the same numbers going from 19.1 and 15.6 respectively to about doubling in terms of the ideal rate of fiber consumption. Going through the same kind of analysis we would get to, so anytime you look at a disease like cardiovascular disease and impacts upon it, because it is so prevalent and because it is so expensive, healthcare interventions or nutrition interventions that are designed to address CVD, CHD are those that are the most impactful in terms of healthcare reductions. They're the most impactful in terms of healthcare improvements or health state improvements, and so they are the most impactful in terms of healthcare reductions. So we estimated this. These are getting to be pretty big numbers. We saw some of those bigger numbers, again, with the plant sterol research that I cited earlier in the presentation. So eat your special K, right? Eat your special K. Leading to, again, just a slightly different way of presenting similar information from some very pessimistic assumptions to a number that's probably worth doing. And then going on up to in the universal case, right, when things go really well, a number that is certainly worth thinking about. The truth, probably somewhere in between. Our goal, make the economics more precise as we continue to engage in what we believe to be an important and impactful line of research. The last, or the most recent thing we've done. So I haven't mentioned all of the things that have been done in this line of research. I've not participated in all of them. So my colleagues have done some work in the US as well, looking at monounsaturated fatty acids, looking at the potential healthcare spending impacts in the US of adopting greater adoption of the Mediterranean diet. And so that work is ongoing and it's fine. I haven't put it in the presentation today, focused on things that I've played a significant role in. So I received a grant a few years ago from Manitoba pulse and soybean growers. And so we use that research, or that funding, to continue our line of research, again with Mohammed, myself being on this paper, the PI on the grant, as well as the senior and corresponding author, published in Nutrients, again, a really good food science journal. That's one of the things that's been kind of nice about this. The interdisciplinary research has been really fun to work on, to learn something about the science, to engage with my colleagues in other disciplines, and also to have the opportunity to carry out applied analyses with them. And it's been really cool to publish this stuff in some high impact factor journals in the food science and nutrition and dietetics areas. So it's been kind of cool, and it's been really fun collaborative stuff. So this just came out this summer. We completed this analysis, published on July 22nd of this year. So ongoing line of research for us, and new things that we're doing that I'll talk about here in a little bit. So again, sponsored a grant that I held from Manitoba Pulse and Soybean Growers. Actually, when I received the grant, it was Manitoba Pulse Growers Association. And also our colleague, Chris Marinangeli, a former PhD student, a PhD recipient in human nutritional sciences from this university, and now a director of regulatory affairs or something like that. I might not have the title just right, at Pulse Canada. So Chris, really well-trained PhD and someone with interest in this. So dietary pulses. This one's kind of important to Manitoba, right? This hits home. So the government folks and our associate dean research and our dean and a lot of people, certainly the food processing industry in Manitoba, really excited about the protein highway, about new processing facilities for pulses, multi-million-dollar investments, hundreds of millions of dollars in the province. So a lot of wins to be had here. So most of the scientists in the room will probably know more about pulses than I do. But as most of us know, dry beans, beans, chickpeas, peas, chickpeas, lentils, etc. been eaten for a really, really long time, have some really, really great nutritional characteristics, and if you put enough ketchup on them, also taste good. Don't put ketchup on your, but it's going to, right, too much sodium. So you got to be careful what you eat. I'm going to talk a little bit about some of the limitations to the methodology, but Pulse is potentially like a really nice Canadian success story, a world leader in pulse production and processing, and something that we want to pursue, I think, as a province and as a country. So pulses are good for you and you should eat more is what this slide says. So Canada's Food Guide says 2 to 3 daily servings of the meat and alternatives group, including pulses. Only 13% of adults report pulse consumption at an average of 113 grams on any given day. So for a lot of what we do in this line of research, we say, okay, here's what people are eating right now. Ideally, they would eat this much. And so for pulses, as you'll see, and I'll get a little bit into more detail with this set of results than I have with some of the previous. But essentially, the number we start with is 0 because almost nobody eats pulses, right? We want to improve that. One of the things that's hard to do is to convince people that it takes money to make money. So you have to spend money to get something. And we got to do a better job of promotion. Governments are confounded on a much larger scale with the same thing that deans and associate deans are, which is that there's a lot more things to spend on than you have money. And so, but I'm strongly of the opinion that when it comes to public education on healthy eating, you got to spend it. It isn't going to pay you back for a little while. We have the responsibility to leave a better world for our children and hopefully a less tax burdened world for them, importantly. So we got to spend the money on the strategies. So same old same. In this case, we're looking at type 2 diabetes and cardiovascular disease as being what I call food-related chronic diseases that can be impacted by consumption of pulses. Typical kind of 4-step approach, presented slightly differently, same old same, right? How many people do we think we can get to eat pulses at a level that will impact their health? So success rate, what happens to your body that's good? What happens collectively to lots of people's bodies that's good and reduces overall incidence of disease in society? And how much can we reduce healthcare costs as a result? So kind of the same old same. Don't worry, this is the last one I'm going to go through. Painfully, it's also in the most detail, but I won't spend a lot of time on the actual numbers, just to show you kind of what they look like. So we've been improving the methodology as we've moved along. So we did some things for this valuation that we didn't even contemplate for the plant sterol valuation because we were so new at it. And I think the fact it was published in good journals is evidence that it's considered to be important research, that we've been filling a gap in the literature along the way. The stakes are huge, billions of dollars. So that's huge to the healthcare industry. It's huge. This is money that should be going to fund university research, not being spent needlessly on healthcare because people can't figure out what to eat or what not to eat, for example. So what did we do? So LDL-C cholesterol and systolic blood pressure. So adding some things to the analysis, refining and making it more sophisticated as we go along. I'll speak more about that in a little bit. Also presenting some confidence intervals and some discount rates. So I've just said we got to spend money to make money. Well, okay. So when I used to teach ABIS 1000 in this room, I lecture in this room thrice weekly with econometrics, I think, as I've mentioned. But we learned about discount rates and net present value. So if you're going to make an investment, you got to figure out if it's going to pay you back. And that's some of the work that we're starting to do too, to look at those future savings that result and get them back to today's dollars to help decide, is it worthwhile making an investment? Here's what some of the assumptions look like. So I was sort of saying earlier, if 13% of the people consume pulses on a daily basis, we're effectively at 0. What would we like to do? Well, we've got 0 grams per day on average, right? What would we like to get to? 100 grams per day. Seems doable. And we're looking at things like, so T2D, type 2 diabetes, and reduction in glycated hemoglobin. What's going to happen there? Cardio, so addressing type 2 diabetes over there on the far left, cardiovascular disease, in terms of cholesterol reduction, but also in terms of blood pressure reduction. Okay, so systolic blood pressure, dealing with hypertension. So kind of a new disease that we've been adding to our recent analysis. Another thing that we did this time was break it down by province. So we don't have, there are no studies that I know of or that are easily available that pertain to the health conditions of people in Manitoba versus Saskatchewan. There are subsets of the population, I think, that are known to be at higher risk for food-related chronic diseases. I'm going to talk just a little bit at the very end about Templar, a study that I'm hoping to contribute to in terms of economic analysis that I'm a collaborator on, that we are going to be sampling real data from real individuals in real populations and some very high-risk populations as well. So we see scenarios taken out. So the reason why you've got some differences is because the cost structure of healthcare from province to province changes slightly. So that's why there are differences from province to province. So we've got those. We've got our lists of different types of cost categories still. We've got our 4 scenarios. And when we go through all of that, we get the savings that we were looking at. Okay, so in millions of dollars, very optimistic scenario or universal scenario that we've talked about before with some significant savings as a result of pulse consumption. Again, by province, differences that exist due to slightly different cost structures. You'll see the numbers are really close, but we do have different data for different provinces. So dietary pulse costs, or dietary healthcare cost savings as a result of pulse intake. Again, specifically looking at diabetes, looking at cardiovascular disease, and when looking at cardiovascular disease, looking at reductions due to bad cholesterol and due to lowered blood pressure, or high blood pressure as a negative thing. And then discounting things. So kind of rushing through this set of results, but looking at across the matrix of potential savings. So big numbers, big numbers. At the end of the day, discounted savings scenarios every 5 years. So I'm happy to send this. Anybody interested in seeing this paper, please just email me and I'll send it along to you. It's an open access journal, and so I have no problem sending you a copy of this. So, remarks just on this last study that I've cited. So, substantial reductions in type 2 diabetes and cardiovascular disease-related diseases. So, what could we do? Public health strategy. How do we publicize this? So, just before the seminar started, Derek and I were talking a little bit about individual discount factors. So we do things that are bad. We knowingly do things that are bad for us. We knowingly eat things that are bad for us. How do we affect that? This was the whole idea when they started to print really, really nasty pictures on cigarette packages. I'm sure everyone or almost everyone has seen those. That's the idea. Help people understand what will happen if you engage in this unhealthy behavior. So I don't think anytime soon we're going to get away with printing pictures of people laying in hospital beds that have had strokes, are really, really obese or whatever, on food, on packages of Twinkies, I don't know, or whatever, right? I don't think we're going to get away with that anytime soon, but that's the idea. How do we get people to understand the consequences of their decision? And even if the consequences of their decision were only on themselves and their family, right? The pain of watching somebody that you love suffer greatly. So, but it's also the tax implications. It's also the fact that we have no choice but to spend these dollars that could be better spent on other things, like higher stipends for associate deans in agricultural and food sciences, for example. So what's next? So there's an overview of the half a dozen or so empirical analyses that we've done. What are we doing next? There's some things. We could do something like look at some alternative approaches. We think cost of illness works really well. One of the things that my PhD student is working on is a behavioral conceptual model. So you need to understand what people are actually going to do. So we've said I think there'd be pretty near universal agreement that we should eat healthier because we'll feel better, we'll live longer, and we'll spend less of other people's money on taking care of us. But we got to understand what motivates people in order to change behavior. So these factors, so offsetting behavior, if I eat something good today, then that means I can sort of cheat tomorrow on my diet or whatever. So offsetting behavior is a big potential part of all of this. So you probably can't see everything that's in the boxes, but one of the things, so we had some research funded through a Consumer and Market Demand Research Network from Agriculture Canada a few years ago, and looking at this conceptual model from motivational stage to, so what's going to make me change behavior, to volitional stage, what's going to make me resolved to actually do something and to engage in that behavior, efficacy stage, how will that behavior manifest itself in terms of a change in a health state, and then what economic benefits could result from that. So we're getting, again, to a little bit of more work. So in these kinds of analyses, we're done by people who are really, really smart and trained healthcare practitioners, etc. We're kind of doing their own economics in some cases. And the analysis, we're trying to continue to evolve it. Certainly in the nutrition economics field, these are the kinds of things that we're thinking about conceptually. So the proposal that my graduate student will be doing in a couple of days in terms of micro is specifying or proposing a new approach known as micro simulations. So instead of having to look backward and say, okay, so our colleagues in food and human nutritional sciences can understand the meta-analyses that have been done. So meta-analysis is an analysis of a collection of other studies to come up with some kind of an average impact on, say, reduction in LDL cholesterol when people from across different studies and different populations and maybe different countries or even different continents all do kind of the same thing, maybe with slight variations, and a meta-analysis gets you an average out of all that. And then we cite these when we want to know what's going to happen if people eat healthier or less unhealthy, as the case may be. What's going to actually happen to them physiologically? Well, we base that on the meta-analyses, and then we work on the economics ourselves. So what a micro-simulation might do instead is to simulate the life of an individual. And then when you do that enough times, because computing power has gotten really, really, really good compared to when some of us were, younger or in graduate school, you can do some simulations. You can construct a population artificially that assumes different things, but researchers in human nutritional sciences have gotten really good at this, and it models an actual life course of an individual. So you can play with the assumptions at various stages and see what happens as a result of that. So it's something that we're working on, and it allows for a little bit more what-if scenarios rather than working off some older data. So it generates what we consider to be plausible health outcomes for these synthetic individuals, and then we can do empirical work on that data. This looks kind of similar. It actually comes up pretty well on here. It looks kind of similar to what we've been talking about before. And so you have a decision in that sort of planning phase that we talked about a few slides ago. Are you going to consume, not to consume? If you do consume, but decide that because you were good this week, you can be bad next week, or if you were good today, you could be bad tomorrow. How does that affect the efficacy? So the Framingham risk functions from a seminal study of how these relationships actually work empirically is something we've relied upon. It's a little bit of the basis for what we've done. So do you develop, for example, cardiovascular disease or not? If so, do you die from something else? Or is there some other kind of thing that you're dealing with? And so we then blend that into the costs and of morbidity and mortality as well. And again, potentially expanding the cost to other sectors of the economy. So we think this is a pretty good approach. It may allow for some more precise estimates. So you're assuming something one way or the other. We like to use empirical data as best we can. There's always some assumptions to be made, and as long as you state them, that's okay. We could probably do some things that are a little bit more detailed, which we like. We could probably target. So we can model people who are like many of the folks in this room who are healthy with higher income. So we can look at that. Or we could look at just a population subset of a particular target demographic that we maybe know has a higher incidence of a food-related chronic disease and that we're trying to help especially, that might comprise an important part of the population. We could also be a bit more forward-looking with a microsimulation approach. So it's something we're working on and hope to incorporate into our ongoing work in this area. So the other things we're going to do, so some folks, a former master's student of mine here who happens to be and then went on to do a PhD at Texas A&M University, now is employed in the US and is working on this. So this is some of the things we have him working on. There's a lot of ranges of these potential costs, right? Remember the first one, from 38 million to 2.5 billion? That's a really big range. That was where we started. That's where we started with this stuff. We'd like to add a risk component to that, to not only reduce the range of possible outcomes, but also assess or take account of the fact that there are a lot of different things going on. Rather than saying there's an expected value of this or a mean, we recognize that there's a distribution of potential outcomes. And there's lots of different distributions. So I torture my students in this room regularly with discussions of the normal distribution and standard normal distribution and chi-squared distribution and F distribution, etc. But there are many others that could be appropriate for modeling these. So there's inherent uncertainty across the discrete steps that we've used this far. So how could this be used to then simulate the distribution of expected healthcare costs? What happens if we relax some of our assumptions? What happens if the parameters associated with specific cost categories in indirect and direct costs of hospitals, etc., can be relaxed? We say, well, this is the most likely outcome, but there's some outcomes out here in the tail that could happen as well. So it's something that we're working on. These are some of the areas that we're trying to refine our approach, which even though has been published in some really great outlets and we're very proud of the work, still we're trying to make it even better. And that's our goal for some of the work moving forward. And the last thing, actually I was going to do a little bit of a plug for Templar, which has got, which is a huge research project, $1 million research project here at the U of M. But I talked a little bit too much, and so I'm not going to talk about Templar except to say we're pretty excited about actually gathering data from real live humans that take into account their socioeconomic factors, their genetic makeup. We can start tying these to health outcomes, and we're going to be able to do even more interesting things with respect to our nutrition economic research as a result of this. I told Martin that my goal was to leave no time for questions. I have almost accomplished that at 4:28, but nevertheless, that's a little bit of an overview. And so last thing to get to is just, again, this is where we're at. We've got government, university, industry, farmers as partners in all of this. The stakes are high, but it's a feel-good story and something really positive and be optimistic about as we collectively together try to move the agri-food industry in this province forward.
Thank you, Jared. So I don't want to let him escape without 3 questions. Derek.
Well, the first question is, what are the economic benefits of consumption of beer? And I sign up for this.
We can, that's great. So we can do some testing together. I do believe in collaborating with my colleagues in the department as well.
But I do have a more serious one. When we save all these people from diabetes and cardiovascular disease, they live longer and then they get Alzheimer's. And isn't that a more expensive sickness?
We hope they don't. But that is a fantastic question. We receive it often from reviewers. It is one of the extensions of the research that we're working on. We know that, yes, if we make people healthier, they're going to live longer. Really what we're looking at is a period of life with ideal health or nearly ideal health. If someone lives to 80 instead of 65, yeah, they're alive 15 more years. But maybe of those, a greater number of years are actually healthy years than the person that lived to 65 but was a train wreck at 40. So that's a great question, and that's one of the things that Colin's microsimulation approach is going to help us answer. Thanks, Derek.
Someone at the back with a more uplifting question? Selena.
Do you think there's any benefit in actually paying people to eat more healthily?
There could be. So the question, could we pay people to eat more healthily? Usually those things take the form of subsidies for healthful food products. But for some segments of the population, you bet. The government is going to spend money on people. Would it rather spend money on taking care of people after it's too late and they're sick and that quality of life is terrible and we're stringing people out? It's our duty to keep them alive. And so would it have been better to pay them? It takes money to make money. I think that's a really profound point. That may be true. I think that's a great question to explore because the answer could provide a lot of guidance for our regulators and government people. Great question. Thank you.
It was a recent report from the Manitoba government about the visits to emergency rooms.
Okay.
What are the factors that you see that are behind less visits to emergency?
What are the factors that are behind fewer visits to emergency rooms? I don't know. I don't know. I haven't. I don't think I'm familiar with the basics for. Pardon me?
Just last week, there was an announcement that it was less visits from Manitobans to emergency hospitals.
There might be less visits to emergency rooms because we've closed them. But I don't know. I hope it's because people have been eating healthier. That's my fondest desire. But I'm afraid I can't offer greater insight than that. Thank you, Gustav.
Anita?
I have a question, Jared. In terms of your economic analyses, one of the things I'm not sure about in terms of the factoring is the cost of me taking on another behavior and who's bearing that cost relative to the healthcare system later on, and whether the individual cost of engaging in a particular activity has been factored into your economic analysis or not.
So Anita's question, for those who couldn't hear in the back, you're asking me to take on better behavior, healthier eating, or less unhealthy eating, etc. Who pays for that? Good question. I think it kind of relates to Selena's question as well. I think that at the end of the day, we should be spending money to the margin to help you with that decision. Probably in your case, you don't need the help. And my hope is that for people like you, the staving off a poor future health state that you know will be uncomfortable and years of painful living should be enough of a motivator. Could the government, again, play some role in that? Potentially. I think so. Our analysis has not taken account of that, but I think it's something that is important. So there's a public health education strategy component of this, which is where most or all of the money should actually go in the short term from any savings that might result. And short term for this kind of work, 10 or 15 years. So who's going to pay for you to eat healthier? Hopefully you'll realize that that leads to a better quality of life, but hopefully also the government's going to be there or others to help make those good decisions. So thank you, Anita. That's a good question.
You've got regulators creating guidelines and food industry creates advertisements. So you're incenting people to eat healthier through education. And I know that we're not at the point where we're printing hospital beds and Twinkies, but is there any thought to disincentivizing poor choices?
Well, there really is, and I think we've seen those kinds of policies other places. Yes, there's soda taxes in different places. I think one of them was just repealed. So again, we economists have something important to contribute because we would have told people. So when I used to teach an undergraduate course on health policy, basically, or food and health policy, we would take up papers where scholars would show everyone thinks it's like smoking. Raise the price of cigarettes and you'll cut down. There's no other alternatives really, realistically, to smoking. So you could ban cigarettes or you can make them more expensive and that will reduce usage. But if you make soda more expensive, people may drink something else with sugar in it and you can't really ban it because people will get it somewhere else. So I think the disincentives could work, yes, but they have to be carefully developed and targeted. But sure. And again, maybe that disincentive to a really poor future health state isn't enough. Maybe it is for some of us, but everyone has different utility functions and discount rates about that future unhealthy state of their life and quality of life. But I think that is a very valid possibility because it's cheaper. With the stroke of a pen, you can create a disincentive. To create an incentive can be really expensive. So it's certainly something worth considering. Good question.
One final question, Jared?
Can it have to relate to beer?
Does it relate to beer, Chantal?
Well, ask it anyway.
Related to industry.
Okay.
Just how, so everybody in the room probably super interesting story. I know I'm excited about it, but how do we get the right people excited and the right people who are going to do something about it? How do we get industry to line up to your door? I'm assuming that the three, the Pulses and the Kellogg's, it's all from past relationships. We've already done that. But how do we get the Nutgirl, like all of the different associations, how do we get them to line up to complete this analysis with you? And then also, secondly, is just how do we get the policymakers excited and using the data to become more proactive and preventative messaging? How do they use your research or your area's research to change?
So good question. I received an email from government staff yesterday saying, we're aware of your research and we know you've been in discussions with some of our colleagues. We want to sit down in January and talk about how to move this forward. I think that was just wonderful to hear. I think that it is hopefully the connections that we have as a faculty have in our researchers and with Martin's office and yourself as research coordinator or facilitator. I think that's important. So we got to spread the word. We got to get excited. We got to approach people and get them involved. Agriculture and Agri-Food Canada, who's supported this research in the past, has recently sort of reignited, I think, their policy networks, or at least what will become similar to them. So I think there are some opportunities, but we need to have a discussion with government, with industry, where are we really going to go? Because like everything else, the dollars are scarce, so let's do it once and do it right. And I look forward to working with you and with Martin and with other scientists in our faculty to help keep the ball rolling, I would say. Thank you, Chantal.
Okay, well, I'll give a small token of our appreciation if everyone
Thank you,
can
sir.
thank Jared again.
Thank you.